itself is even self-explanatory. So this is the normal anatomy of the female reproductive organ. So sometimes you'll see like the ovary part is actually having what? The ovary part is actually can become cancerous. So that is when we call it ovarian cancer. So what is expected at the end of the session? At the end of the session, you are expected to identify what are the possible risk factors that can increase the risk of ovarian cancer in all female population. Then, what are the signs and symptoms of ovarian cancer? And finally, you should be able to describe or outline the treatment options for ovarian cancer. So that is the main objectives we are going to achieve at the end of the session. So when you say ovarian cancer, it usually begins in the ovaries, and it is actually relatively uncommon, but it is most fatal gynecological cancer. So it is mostly captured in the by gynecologists when they are doing routine examination, but finally later on they refer to the oncologist for further review. Then most of the ovarian cancer are of epithelial origin. So that is where the cancer undergo malignant transformation. And most of the time they are confined within the abdominal cavity, but there is a possibility of a spread to other parts, liver, most probably lung, then less commonly bone and brain, but still it has a potential to undergo metastasis to other organs. Then there are three kind of cells in the ovary. Then each type of cell can develop into different type of tumor. We shall see it in the next slide. So if the tumor starts from the cells that cover the outer surface of the ovary, we call them epithelial tumor. And as I said before, this one is the most common ovarian tumor. Then, if it grows from the cells that produce egg, we call it germ cell tumors. And also, when it starts from the structure that holds the ovary together, or and like the structure that produces the female hormone estrogen and progesterone, we call it stromal tumor. So this is epithelial. This one is from the germ cell that produces ova. Stromal cell is actually a cell that produces the female estrogen and progesterone. So you can actually even see this type of tumor in a patient with ovarian cancer, but epithelial tumor is usually the most common type of tumor in the female reproductive tract. Then, how do you see about the epidemiology of ovarian cancer? It is actually the seventh most common cause of cancer deaths in the human in the US. Then it is also the third commonest cause of cancer deaths from gynecological tumor, even in Kenya too. So you can actually even see most of the time, like this condition is asymptomatic until the woman reaches to advanced stage. So because of that, most of the cases are diagnosed or captured in advanced stage. Yeah? I think that is why it is also known as a silent killer type of malignancy. Then you can actually even see majority of the cases are diagnosed over 50 years. Yes. Then the high mortality of ovarian cancer is related to like slow onset and non-specific symptom. So because of that, most of the patients will not present symptom until they reach stage 3 and stage 4. So that is why this condition is really highly fatal. So once it reaches to advanced stage, it is very hard to treat and it is to cure the disease. So that is the most contributing factor for high mortality rate of this condition. Then, according to WHO histological classification of epithelial tumors are different types. So you're not supposed to bother about, but just have some idea about what are the histology type of epithelial ovarian tumor, because that is not like the scope of like the for pharmacy student. Then the serous type is the most common type of epithelial tumor, which accounts like 80% of the cases. There is also endometrioid and clear cell. So this is the role of the pathologist to specifically indicate what type of epithelial ovarian tumor the patient is having. So the most common ones are the serious type, the most common type of histological classification. Then what is very important and give much emphasis is how does how does ovarian tumor can happen. The exact causes of ovarian cancer is not really known. Even the pathophysiology is not really known, but there are actually different hypotheses that suggest us about the pathogenesis of this condition. There is one theory known as insistent ovulation hypothesis. So, according to this hypothesis, ovarian cancer is usually connected to continuous ovulation. So, according to this one, when the mother is actually continuously ovulating every month, the risk of ovarian cancer is very high. Why? When there is a repeated ovulation, now what will happen as a result of this process? There is a greater number of repairs of the ovarian epithelium. Because of damage, there is a lot of repair in the epithelium. Then this ultimately increases possibility of like wrong repair. Then this undergo mutation, then undergo malignant transformation. So that's why they are saying if a mother is actually is continuously ovulating, like without having a child, then the probability of ovarian cancer is very high, according to this hypothesis. Then the other hypothesis, why? When there is ovulation, there is actually damage of the epithelium. So as a result of repairing, there is a possibility of mutation or wrong repair, then this causes malignant transformation. The other hypothesis is the Pythagorean gonadotropin hypothesis. According to this one is related to, they are saying ovarian cancer is related to gonadotropin and estrogen level. So what will happen when there is an increase, the number of follicles, and there is an increased risk of malignancy. So like this one is mostly due to the increased level of gonadotropin, estrogen, and ultimately increase the follicle, then there is a possibility to undergo malignant transformation. So this is also another hypothesis. Then the other thing is uh, ovarian cancer is due to chronic inflammatory process. So they are saying when there is a chronic inflammatory process in the ovary due to environmental carcinogen, now there is a possibility of ovarian cancer. So, but in ways, those are some of the hypotheses that can suggest the possibility of ovarian cancer development in the female population. So, having said this much about what are the possible risk factors, the exact cause is usually unknown, but there is a significant risk factor is usually a linker to aging. So as you age, the higher risk of ovarian cancer. Then apart from that, family history of ovarian cancer. So if someone is having first degree relative with ovarian cancer, there is twofold increase in risk, which is very, very common. Then, do you remember what we mentioned in breast cancer? BRCA1 and BRCA2 mutation. So, as I mentioned when we are discussing about breast cancer, BRCA1 is a breast cancer antigen. So, this is a tumor suppressor gene. So, when there is a mutation, there is loss of function of this tumor suppressor gene, and ultimately, the progression to cancer is usually very high. So, it is more prevalent, and you can actually even see like BRCA1 mutation is more prevalent and being associated with 90% of hereditary type of ovarian cancer. So when a mother or a woman is having this mutation, there is high risk of ovarian cancer too, apart from breast cancer. Then nulliparity. So this nulliparity is as a result of like is related to frequent or repeated ovulation. So remember this nulliparity will support this hypothesis, which propose ovarian cancer is due to continuous ovulation. So when there is nulliparity means as long as they are actually fertile, then there is a continuous what ovulation every month. Okay, then Early menarche and late menopause, it is related to the hormone exposure. So it can actually explain the pituitary gonadotropin hypothesis as well as the insistent ovulation hypothesis. So when someone is having early menarche and late menopause, they do have prolonged ovulation as well as they do have prolonged exposure to the hormone. Because of that, you can actually even imagine this one can also increase risk of ovarian cancer. So this is something you're supposed to note in terms of risk factor. Otherwise, there is no a single risk factor that is linked to ovarian cancer. So those are the only factors that can be correlated to ovarian cancer. Then, apart from that, there is a possibility of some association between dietary and environmental factor. A diet rich in high galactose animal fat may increase the risk. So I don't know about the real connection between this condition, but anyways, if someone is eating animal fat and meat frequently for a long period of time, there's increased even ovarian cancer. We shall see even there is a strong correlation, by the way. Maybe if some of you are actually really interested, you can think of about colorectal cancer. Where there, like nowadays, there is a strong association between there is a strong association between red meat and colorectal cancer nowadays. So if someone is actually consuming colorectal cancer, sorry, red meat for prolonged time, there is high risk of developing colorectal cancer. Okay, fine. So that one we can point out later. But if some of you are actually interested in this kind of project, you can further read and actually fine tune how you are going to like come up some solution or come some kind of studies like to see the connection between red meat and colorectal cancer in the Kenyan population. Then vegetable-rich diets, they are usually counter protective. So they are very important and they protect from having ovarian cancer. So most of the time, if you want to reduce risk of having cancer, eat more vegetables. So I think in the vegetable, there are different nutritional components that can prevent abnormal growth, proliferation in the body system. Then asbestos and talcum powder use, I don't know where we can actually get even this kind of exposure. Maybe in the chemical industry, when someone is actually having this exposure, there is high risk. So those are some of the environmental factors. Okay, then now, is it possible to screen? Is it early screening is possible with ovarian cancer, like what we did for breast cancer and what we have seen for cervical cancer? So far, there is no standard and effective screening tool that can capture ovarian cancer at the early stage. In fact, that was the major issues, even why the patient is actually developing advanced stage without being recognized. There is a pelvic examination can work, but it is usually more noticeable when the disease is advanced. So if they do pelvic examination in the early stage, they might not actually really identify whether there is a malignant transformation or not. Then the other thing we are going to look at is the serum level of cancer antigen 125. But please don't forget if you see a patient with ovarian cancer, expect CA125 in the diagnostic test, as well as even in the screening, as well as even in monitoring of response. But it's not a specific tumor marker, but it is most commonly used in ovarian cancer, even in our setting. So don't forget, CA125 is the most common tumor marker that can be used for ovarian CA. Okay, good. Now, look at transvaginal ultrasound. So not specific and inability to detect when there is when there is a peritoneal cancer or cancer in normal size ovaries, unless like ovary undergo grows, this even transvaginal ultrasound will not even detect. But for high risk women, the recommendation is like if there is a mutation of BRCA1, if there is high first degree relative of ovarian cancer, Now, it is usually recommended yearly ultrasound combined with CA125 every 6 months is usually recommended. So this one is usually recommended for high-risk women. Okay, then is it possible to prevent ovarian cancer? Yes, with a slight extent, because as I said in the pathogenesis of ovarian cancer, ovulation is the one that makes for the ovary to have more damage and to become cancerous. So any condition that limits the number of ovulation will protect from ovarian cancer. If so, according to epidemiological studies, those who are having multiparity will have lower risk of what? Ovarian cancer, because they do have limited number of ovulation because of multiparity. And apart from that, chemo prevention, those who are using hormonal contraceptive, remember what we have discussed in the fall semester 2020, oral contraceptive, how do they work? Huh? Most of them, they prevent ovulation, yes? Yeah, by inhibiting the negative feedback mechanism, the positive feedback mechanism, they normally arrest ovulation. So because of that, oral contraceptive, hormonal contraceptive, they are actually chemo preventive medications. Okay, so you have to know, then oral contraceptive reduces ovarian cancer risk, but hormonal contraceptive increases what? Risk of breast cancer. By then you have to know the difference between the two. Oral contraceptive by inhibiting ovulation, it reduces ovarian cancer risk, but oral contraceptive by increasing the level of the hormone, it can increase the risk of breast cancer. However, this chemo prevention is usually not recommended for a family with a woman with a family history of breast cancer. So this one will not be an ideal candidate for this preventive measure because of the risk of breast cancer. So that is very important. Then, according to even some guideline, there is a possibility to consider even prophylactic surgery for high-risk women. High risk, that is having family history, then mutation in the BRCA1 gene, consider to undergo like surgical resection of the ovary and even the fallopian tube and tubal ligation. So like you normally prevent ovulation. So those are some of the circumstances that can be considered to prevent ovarian cancer. So if you see the whole aspect of prevention modality, all of them are normally preventing what? Ovulation. Okay. Then let's see about the staging of the disease. Staging of ovarian cancer. So stage one is usually limited to the ovaries. Stage two, the growth can involve one or both ovaries, but there is extension to the pelvic region. Stage four, the tumor involves one or both ovaries, but there is actually involvement of regional lymph nodes. Stage four is the one that is, it can involve one or both ovaries, but there is a possibility of distant metastasis. So this is the staging of TNM, staging of ovarian cancer. So as I mentioned before, stage 3 and 4 are the one that is mostly diagnosed in our setting because this condition is mostly asymptomatic in the early stage. Okay, so this is like a diagrammatic representations of the ovarian stages. So you can actually even see how the cancer look like in stage 1. You can actually even in stage 2. Yeah, there is a possibility of pelvic extension. But in stage 3, you can actually even see there is involvement of different lymph nodes, but stage 4 is normally split to another organ. So this is something you are going to note what is the difference between stage 1 to stage 4 disease. Then now, let's see about the clinical presentation. As I mentioned before, ovarian cancer is a silent killer like hypertension because there is no specific sign and symptoms. That is why it is known as a silent killer. Then, if the cancer is confined to the ovary, most of the patients are usually asymptomatic. Because of this, like this will actually makes the diagnosis very difficult in the early stage. So that means in the early stage, most of the patients are asymptomatic. Okay, then. So that means the symptom will be very common in advanced stage. So if so, what are the clinical presentations that can happen in advanced stage? Abdominal pain or pelvic pain, constipation or diarrhea, urinary frequency, there is a possibility of vaginal bleeding. There is also a possibility of, just a minute. Apology, I'm back. Abdominal distension and fatigue, that is actually very common. So those are the symptoms that can happen in the advanced stage of the disease. Okay, good. Then in advanced stage, by the way, there is a possibility of ascites and abdominal mass that can cause even bloating, abdominal grease, nausea, anorexia, and early satiety. So this is when the disease is actually very advanced and when it involves the liver. Okay, then it can actually even extend to the diaphragm and produces pleural effusion. So yes, so those are some of the symptoms that can happen in advanced stage. Then diagnosis, history and physical examination is very important. Then we take adequate history from the patient, then do physical examination. Then laboratory test, CA125 level is usually very important, despite it is not specific. By itself, it is not diagnostic for ovarian cancer, but it gives us a clue whether the patient is really having ovarian cancer or not. So the normal value is usually less than 35 units per ml. So if it is elevated, we expect there is a possibility, but we have to do further tests. Then CA is carcinoembryonic antigen, the most common marker in colorectal cancer, and CA19-9 can also be considered, but in our setting, this one is the most common. Okay, liver function test and serum creatinine may be suggestive of extent of the disease. Remember, there is a possibility of involvement of the liver, so there is a need to even assess the liver function test. Okay, then the most confirmative or the diagnostic confirmatory diagnostic test is usually biopsy from the site of the lesion. So those are the most important thing. Then the other one, abdominal ultrasound, even transvaginal ultrasound will give us a clue, but it might not be diagnostic. Okay, without doing biopsy. But those are the early tests. They check this one, then abdominal ultrasound or transvaginal ultrasound, then they consider biopsy if those results are abnormal. Okay, so this is how they came up with the diagnosis of this condition. Are you okay so far? Maybe any question before we start discussing about the treatment modalities? A question?
Yes. Is there correlation between the ovarian and the cervical cancer due to the maybe the fact that they're all in the reproductive system?
Okay, as far as I know, there is no correlation unless they do have some kind of genetic problem that can predispose the patient to have that. Otherwise, cervical cancer is mainly due to human papilloma virus. Almost 99% of cervical cancer is due to viral infection. But of course, the aspect of immunity is very important so that the HPV will increase. risk of malignant transformation of the cervical region. But this one is mainly due to ovulation problem, frequent ovulation, those risk factors what we have seen. So, like so far, there is no correlation. But if there is a genetic mutation, there might be a possibility. Yeah? There might be a possibility. Otherwise, there is no correlation in terms of risk factor between cervical cancer and ovarian cancer. So they are independent type of cancer in the female reproductive organs. Good question. Any other? So I'm hoping by now you have a clue what is ovarian cancer and what causes and how it presents and how do we make a diagnosis. If you know this, I think you are good to go. Then, how do we manage ovarian cancer? So according to the different guidelines, mainly as I mentioned, the ISMO and NCCN guidelines, those are actually the most commonly used along with the national guideline. So a multimodality of approach, including surgery, chemotherapy is the initial treatment of ovarian cancer with a curative intent. So there's a component of surgery. In fact, surgery is almost mandatory for all type of ovarian cancer, for all stages. But for advanced stage, the goal is just palliative. So our goal is just to cure, is one of the most curable type. Okay, the major issue with after surgical resection is after we achieve complete response. Initially, greater than 50% of the cancer will occur within the first 2 years. But then the possibility of recurrence with ovarian cancer is very high after complete response. That is why routine screening, routine frequent monitoring is actually very important. So when do we say the patient was having complete response to the treatment in the context of ovarian cancer? No evidence of the disease that is detected by physical examination or diagnostic test, and the patient will have normalized CA125 values. So if the diagnostic test and CA125 level will not show any evidence of the tumor in the ovaries, that is when you are going to say complete response to the treatment. Specifically, this CA125 is the most commonly used monitoring parameters in ovarian cancer. Then, recurrent platinum sensitive patients have a better prognosis than platinum resistance. We shall discuss, by the way, platinum analogs are the most commonly used treatment modalities in the form of chemotherapy for ovarian cancer. So if they are very sensitive, they do have a better prognosis, and we shall see when do we say they are platinum sensitive, when do we say they are platinum resistant patients. Then, as I said before, surgery is the front line. It's almost a primary intervention for ovarian cancer. So even staging will be done, and normally even biopsy will be done by resecting the tumor. So this one is the primary intervention for all type of ovarian cancer. So a total abdominal hysterectomy with bilateral removal of the salpingopectomy can be done. Anyways, this one is just removal of the fallopian tube along with ovaries can be done. Then remember, the objective of doing surgery is the moment they do debulking of the tumor, like until less than 1 centimeter of the residual disease remains. So like when there is like residual disease of 1 centimeter and less than, there's a correlation between a tumor of less than 1 centimeter and a better complete response to chemotherapy. That is why they do bulking. Then after that, they start chemotherapy in order to achieve complete response in the context of ovarian cancer. Then after doing surgery, the gold standard treatment of care is usually taxane in combination with platinum-containing regimens, usually for 6 cycles with advanced ovarian cancer. Maybe we shall see in locally advanced and even advanced disease, there is a possibility to initiate 6 cycles of taxane platinum analogs. Then, in case if the patient is actually having stage 1 disease, surgery alone might be sufficient. If a patient is having a stage 1 disease, maybe you do research surgery, then you monitor the patient. However, most often paclitaxel is a taxane agent that can be used along with carboplatin. So paclitaxel with carboplatin is the gold standard treatment regimen in ovarian cancer. However, there is a scenario whereby we are going to consider adjuvant chemotherapy even in ovarian cancer. But the most common protocol is surgery, then chemotherapy, or surgery alone in the early stage. However, if the patient is having very bulky disease, or when there is a significant tumor burden, or when the patient is not a candidate for surgery because of comorbidities, now this is when you are going to consider neoadjuvant chemotherapy. So neoadjuvant chemotherapy will shrink the tumor so that the surgeon will can debulk the remaining tumor without having any difficulty. So the recommendation is you give 3 cycles of taxane plus platinum, then once every 3 weeks. Then after that, after you give 3 cycles of this combination, that is when uh, that is when uh, we are going to consider that is when you are going to consider surgery. Then after doing so, after doing so, you are going to continue another 3 to 6 cycles of the same chemotherapy regimen. So you give 3 cycles, then surgery, then after that 3 to 6 cycles of carboplatin with paclitaxels are commonly used in high-grade tumor. So even this one, the oncologist will assess how the tumor is actually bulky in collaboration with the surgeon to make decision about this treatment modality. Then remember, there is also a component, we call it consolidation chemotherapy. So we have given the chemotherapy, taxane platinum. Then this one is usually considered, we have given the first courses of the treatment, like 3 to 6 cycle and mostly 6 cycle. But if the patient is actually having a partial response, there is a consideration to give consolidation therapy to achieve complete remission. So consolidation therapy refers to addition of a cycle of the taxane platinum regimen or addition of a single agent platinum or a single taxane after completion of the first line chemotherapy. So this one is commonly recommended when there is a partial response to the first line. So this one is evidenced by, like you look at the CA125 level. Now it is actually, the reduction is like greater than by 50% from the preoperative level. And there is also like tumor is normally undergo regression. Then the cancer is still considered as taxane or platinum sensitive. So in that condition, you normally give additional cycles of chemotherapy, are usually given until we achieve complete response. So that treatment modality is known as consolidation chemotherapy. Okay, then this is a diagram to show you about the treatment options for ovarian cancer. So most of the time in the early stage, stage one disease, usually you do surgery. Remember, primary surgery is the front line for tumor debulking. Then after that, surgery alone is usually sufficient and you monitor the patient. If there is a relapse or a recurrence, which is above 6 months of treatment, we can actually give 6 cycles of taxane with platinum combination regimen. So by the way, after you normally consider like relapse or it could be recurrent disease greater than 6 months, now that is when you are going to, we are going to consider what? This chemotherapy. Otherwise, usually if there is no problem, just monitoring alone is sufficient. Then, if we normally achieve complete response with these treatment modalities, now we just follow the patient every 3 months. Okay, then the other option is, in case the patient is actually having disease progression after surgery, yeah, within 6 months of treatment, we can consider gemcitabine with cisplatin or bevacizumab plus oral cyclophosphamide can be considered. Yes. So if the tumor is relapsing within 6 months, that is a recommendation. But if the tumor relapses after 6 months, usually this treatment modality is usually recommended. But in advanced stages, by the way, yeah, in advanced stages like stage 2, 3, and 4, after surgery, usually the gold standard is chemotherapy. You give taxane plus platinum. Then, if the response is partial, do you remember what I said about the partial response? Huh? Like the tumor size is regressed, the C125 level is actually reduced by more than 50%. That is when we call it partial response. Now you have to consider consolidation therapy with a single agent, taxane or platinum or a combination. Then if the response is complete, that is when you are going to what? Follow them every 3 months. Then if the response is complete with these treatment modalities, you just follow the same protocol. However, in case after complete response, if the patient is having relapse at greater than 6 months, that is when we say the patient is platinum sensitive. You have given platinum analogs and the tumor recur after 6 months. That is when we say the patient is still sensitive for platinum, so we can consider. However, there is a possibility that the disease will progress despite you give them, like within 6 months. So for this one, mostly they are platinum resistance. So the best strategy will be consider another treatment modalities, regardless of the platinum and taxane. So either single agent or combination agents can be considered, or even supportive care in case of that condition. So this is the treatment algorithm. So in summary, in the early stage, there is a component of surgery, and you monitor. If the response is not good, that is when you are going to consider. Then in stage 2 and above, do surgery first, then give chemotherapy for taxane, and then assess the response. If the response is partial, you consider consolidation. If the response is actually complete, you just monitor them. But if there is a progression within 6 months, you give a single therapy. If there is there's a relapse after 6 months, you consider taxane plus platinum regimen. So this is how we're managing what? Ovarian cancer. By the way, I will ask you again, like before I end the session for ovarian cancer. So make sure you are following. Then, as I mentioned before, this one is the gold standard, mostly in stage 2 to 4 ovarian cancer. So paclitaxel, carboplatin, we give 21 days, every 21 days, then usually 6 cycle can be considered, but sometimes we can actually consider until the disease progression or unacceptable toxicity happen. Okay, then you can actually even see carboplatin, the dose are 5 area under the curve. So what does it mean? What does it mean you give 5 area under the curve of carboplatin?
The dose is calculated using the Calvert formula.
Yeah, maybe can you remind us, Tiffany, how we calculate the dose of carboplatin based on Calvert formula?
The targeted area under the curve, which in this case will be 5, times the patient's GFR plus 25.
Okay, area under the curve times GFR plus 25. Huh? Yes, but this one is the most commonly used formula. You go to like the oncology center locally. So if they notice carboplatin in the regimen, that is how they are going to calculate. So it's just the responsibility they are supposed to calculate the GFR, the area under the curve. It's usually indicated in the prescription. Then you calculate GFR and you calculate how many doses of carboplatin the patient will take. So this kind of mathematical calculation is also very common in the oncology pharmacy before you dispense even carboplatin. Okay, so this is the most common, as I mentioned before. Then, if you normally capture the information, recurrent chemotherapy can be considered. So, in the recurrent setting, the first thing you are going to check is you assess sensitivity to the tumor to platinum class of drugs. But then, if the recurrence is occur within 6 months of the disease, while the patient is receiving the platinum-based regimen, now the treatment is usually palliative. So if the tumor resistance or the possibility with the current protocol, the possibility of cure is very likely. So you just normally give palliative care. Commonly, single agent chemotherapy is considered. However, if there is a complete response and had 6 months of platinum-free period before the disease progresses, now we have to retreat with the same platinum-containing regimen, because that is when you are going to say the disease or the tumor is platinum sensitive. So we can give treatment of we can give carboplatin with gemcitabine or even paclitaxel. But in case if the patient cannot tolerate chemo, remember the performance status of the patient is the one that guides you normally what kind of whether the patient can actually tolerate chemo or not. The European Cooperative Oncology Group is usually between 0 to 5. So like if the patient is actually having ECOG scale of 0 means the patient is actually mobile. But if the patient is having ECOG scale of 5 means the patient is almost immobile, bedridden. So you can actually even read this one. It's very simple. Then you assess the performance status. So if the patient cannot tolerate, that is when you are going to give carboplatin alone. So the whole idea is in platinum sensitive individual, we normally give what? Only we can use the same retreatment regimen because the tumor normally progressed after 6 months of platinum analogs. Okay, now how do we assess the outcome? So CA125 should be monitored with each cycle so that we can see the response. Then patients who have achieved a complete response should be followed every 3 months. So as I mentioned, even in the diagram, if the response is actually good, now you follow them every 3 years for every 3 months for a minimum of 5 years. Okay, then you monitor side effects, especially myelosuppression with carboplatin. Sorry, not carboplatin. Carboplatin also causes myelosuppression, but specifically even thrombocytopenia. But even paclitaxel can cause even what you call myelosuppression. So you monitor. Then in the progression of the disease or recurrent setting, say 111 should be monitored with cycles of chemotherapy. Then of course look at the imaging of the abdomen or the ovaries using ultrasound every 3 cycles of chemotherapy. So this is how we're managing ovarian cancer. Now it is time to question. So did you really capture the treatment modalities of ovarian cancer, Tiffany?
Sir, I have a question.
Yes, please.
Have there ever been any recorded cases where you have a patient who responds very fast to treatment, such that they don't require the full 6 cycles of chemo, for example, and they have achieved maybe complete response before the 6 cycles are up?
Yes, by there is, but you have to continue like there are 2 scenarios, by the way. If you don't see response, you are not supposed to even take the whole cycle. Yeah, if you don't see the response with the minimum duration expected to see the response, you are not supposed to take the whole cycle. So the doctors are supposed to consider to another regimen. But if you see adequate response with that chemo regimen, you have to complete the full cycle, because according to various clinical trials, if you want to achieve complete response, like the duration of the cycle or the number of cycles for a certain chemo regimen is calculated based on the clinical trials. So like for this one, if a patient is responding for this chemo regimen, you have to continue for a minimum of 6 cycles if you want to a complete response. Otherwise, there is a possibility of recurrence. So that is why, as you say, there is a possibility that this is for complete response, continue until the whole treatment protocol, if there is no any side effects. But if no response, you can actually even switch to at the middle of the chemo, at the middle of the treatment protocol.
Okay, sir. One last question. For
Yes.
example, if a patient is experiencing the side effects, do we just manage side effects, or is it possible to switch the regimen? So they're responsive, but they're having adverse effects to a severe scale.
Yes, it depends of the side effect. If the side effect is actually very severe, sometimes even you have to hold. Remember, the side effect can even kill the patient, like neutropenia. It can actually kill with a lot of respiratory tract infection or just even sepsis. So, like depending, if it is mild, you continue the cycle, then you monitor, you manage the symptom, symptomatic management. Yeah, so what guides you is about the severity. For example, assuming if the patient is taking paclitaxel and cisplatin, but the patient is well responding for this regimen, but then paradoxically, the patient was developing severe acute kidney damage. So that condition, you are not supposed to continue the chemo regimen. You have to omit or even hold. So there are actually different management strategies depending on the side effects. So yeah, if it is very severe, hold the chemo and even wait until the recovery. Remember, like if the side effect is hematological, like bone marrow suppression or myelosuppression, hold the treatment, then give granulocyte stimulating factor, and as a result, what you are going to do now, as a result, you normally give time until the bone marrow recover. Then when the bone marrow recover, that is when you are going to introduce. Otherwise, it can cause bone marrow aplasia. So like, that means the bone marrow will not produce any blood cells. So the patient will die of the complication of the chemotherapy. So there are actually different strategies, but the common strategy is normally you symptomatically manage, then hold the treatment for severe cases. Then after that, you consider initiation, restarting of the same regimen, or maybe switching to another regimen. So it's depending on even the oncologists, like they are using different strategies of modalities in case of this condition.
Okay, sir. Thank you.
Yeah. Any other question?
Yes, sir. I have a question.
Yes, please.
What happens in the case that the patient wants to have children in the future? What should they do?
Sorry, if they do have what?
What happens in the case that the patient wants to have children in the future? What is their
that is a good question. But they like last year, I normally prepared a separate slide about for the practical session. You know, we normally did online practicals. So that is when we normally even discuss. So the minimum requirement, by the way, especially if they are on alkylating agent, they are supposed to stay for a minimum of 2 years before they consider like conception or pregnancy. So like remember, like those chemotherapeutic agents, they can actually even cause destruction of the ovaries. Even there is a component of even surgical section. So for that one, there is no option. There is no option. Even if you give them chemotherapy alone, especially if there is alkylating agent, they are supposed to wait until for a minimum of 2 years before they conceive. Maybe I will share that slide. Maybe you can go through it about how we are managing this kind of what is the effect of chemotherapy on gonads. Normally, we really did like a long discussion in that regard. So for this one, no, there is no option because here you measure the risk-benefit analysis. You measure risk-benefit analysis. So, and most of the chemotherapeutic agents they are teratogenic. this teratogenicity is not really only like immediate. There is a possibility of even delayed. Then it can even cause some defect in the fetus. So that is why a minimum duration of 2 years is usually recommended before they consider. Yes, but for this case for ovarian cancer, they usually do surgery, so that is not really possible because they have already resecting the ovaries, which is the main source of the ova. So like it's not possible. Good question, huh? Yes, any other?
Sir,
Yes.
in ovarian cancer, is it one ovary that is affected or both, or it starts in one and then depending on stages moves to the other one?
Yeah, yes. Okay. By the way, like on that one, it can be either, it can be like one or either. Like one ovary can be affected, or it can be both ovaries can be affected. So there is a possibility, yeah. There is a possibility like one ovary can be affected or the other ovary can be normally. That is why if you see even the staging, it can be one or either. It says, let me show you again. So if you see the growth stage 1 limited to the ovaries, but it can be both ovaries, yes? Growth stage 2, one or both ovaries. But the difference is, the staging of the difference is normally either there is extension to the pelvic area, lymph node movement, or distant metastasis. So the ovaries can be one or both. Even in stage 1, both ovaries can be affected, but the disease or the cancer is just within the ovaries. So otherwise, there is no, it's not like breast cancer, mostly which is unilateral and very common in the left breast. But this one ovary or both ovary can be affected at the same time. Okay, good. Any other question? So are you in a position to comment about the treatment option? Maybe if I ask Venetia, how do you manage ovarian cancer? I think that will be the summary question.
Yes, sir.
Yes, please.
Okay, so under the primary treatment for stage 1, we said surgery. If they don't require chemotherapy, then surgery would do. Then so that's the primary treatment for ovarian cancer, which falls under non-pharmacological. Then under pharmacological, you have to do 6 cycles of taxane and platinum. And in taxane, it's paclitaxel. And in platinum-containing regimen, it's the carboplatin as the preferred agents. Then the next thing that you had talked about is if they don't see, if there's recurrence that within 6 months, that's called platinum resistant of the disease. And then and you do paclitaxel and carboplatin 6 cycles if it's recurrent and refractory after greater than 6 months.
Okay, good. Yes. So in summary, what Venetia said is actually correct. So in the early stage, surgery alone can be considered, but in case if there is a progression, consider the chemo, the gold standard. Remember, they are gold standard because they are actually very effective in achieving complete response within the clinical trials. That is why the guideline normally picks like ovarian cancer, pick this one regimen first before you go consider other treatment protocol. Then stage 2, 3, and 4, there is a possibility to consider carboplatin chemotherapy regimen after debulking. But don't forget about the possibility of what neoadjuvant in case of severe, in case of like very bulky tumor. Yeah, very bulky tumor. Then you do neoadjuvant 3 cycle, then surgery. Then after that you give adjuvant chemotherapy, but 3 to 6 cycle. Yes. Then in case of partial response, don't forget to continue the cycle or you give monotherapy. We call it consolation therapy. Yes. So I think that will be enough for undergraduate level for this ovarian cancer. Because you remember for undergraduate level, we normally give like the basic information. So they have to know what is ovarian cancer, what causes, what is the pathogenesis, what are the clinical presentation, what is the diagnosis, what are the preliminary management. If you know this, I think that is more than enough. Huh? Okay, now, if you don't have any further, yes, question. Yes, please.
Someone at the risk of cancer.
Sorry? You are breaking. Is it Angela? Who is talking? Is it Angela or? Is it Makina? Makina, then Angela will follow. Makina, continue.
I'm asking.
Yes.
PCOS put you at the risk of ovarian cancer.
This is polycystic ovarian syndrome. I think it can cause, but I'm not very sure. It can be a risk factor, but I'm not very sure unless I check the information. I've noted, then I will normally, but there is a possibility, polycystic ovarian syndrome, but I will check. Even one student normally can check as we proceed to the session. Then Angela. Yes, Angela, question?
Getting the ovarian cancer, if you freeze your eggs, would it help reduce the risk?
Yeah, yes, please, Angela. I was just normally kicked out because of connection. Then can you repeat the question, please?
I was asking, when you know, like, your first generation relative has ovarian cancer, if you freeze your eggs, would it reduce the chances of you getting the ovarian cancer?
If you
like you have them, but if you remove your ovum and then you have it freezed, would that help?
Is it like you put a reserve, or I don't know?
Yes, you harvest them and then they're frozen for you. Then when you want to have a baby, now the doctor can find ways, if it's surrogacy, for you to have the baby. Can it reduce the risks of you getting the cancer?
But that one is not really like the ovarian reserve. I don't know how they are actually doing that. So there is actually a scenario, what I have seen in the Western countries. They normally do this one. They take some of those things before they undergo this kind of procedure, like a very harmful procedure for the gonads. So they put a reserve. Then after that, they can be actually use a surrogate mother for. I think it is possible, but I don't know which type of cancer. It is very common. Yes, yeah, but I'm not very sure. But there is a possibility. They normally harvest then before the procedure. Yes, then after that, if the ovary is okay, if there is a significant damage, now they can actually be a surrogate mother. Yes, there is a possibility that kind of procedure is also available in the Western countries, but I doubt in African population. Yes, good question, by the way. Yeah. Maybe I further counter check normally what is the current practice on this regard. Then I will let you know. But good observation. Any other? Any other question? Okay, fine. If so, I think we can continue to the other parts of the presentation. Are you all listening, by the way, from the experience with the previous student, especially in terms of project? I think the sooner the better. So unless they change, the current protocol is actually like you choose your own supervisor, then liaise with him, then discuss what kind of research activity, discuss what are you having in your mind. Then after that, start writing as soon as possible. You have already taken the course research method, yes? Research method, I don't know when.
Yes, we have done research methods.
But when? At what semester? Do you have all the materials?
Right now we are doing raw and ethic in research methods.
That one is more of the ethics. You know, the ethics aspect is normally what kind of consent that you're going to have. Yeah, just more of the research ethics, the research misconduct. So, okay, that's one. I don't know whether were there any component of study design in the research ethics course. Who is teaching?
Dr.
Sorry?
We have done, some of us have done the GRM with Dr. Evans.
Okay. The current course ethics?
Dr. Okan.
Okay. I don't know them, but anyways, I think even for that component, there is a possibility. So I'm suggesting, by the way, the sooner the better, because the major problem, what we have encountered is like many students, they are taking many courses, because of the G courses. So because of that reason, there is a possibility of delay. For example, like if you are doing a study on the clinical area, it requires then you can actually even see how the imaging of colon cancer look like. Yes, this one is appendix. This is actually the ascending colon. The sigma. This one is transferred, then the descending colon. Then you will get the answer. Okay. So this is normally the imaging of the colon. So according to the GlobalCan 2018 report, so in terms of incidence, colorectal cancer is third globally. In terms of mortality, colon cancer is normally the second. You can actually see in terms of incidence, the cases are very high, second leading cases. And in terms of incidence, but in terms of mortality, it is actually the second one. So lung cancer is actually the most fatal type of cancer. Yeah, so this is based on the global epidemiology. And even in Kenya too, I forgot to update, but you can see the GlobalCan 2020 report, 1, 2, 3, 4. So it is actually the fifth leading type of cancer in Kenya too. Yes, among all population. Question?
Yes, sir, I have a question.
Okay. Yes, please, Stephanie.
Have any studies been done about the correlation between gout and colorectal cancer because of the shared risk factors?
I'm not sure unless I check. Gouty arthritis is mostly, I think it can be another, but it's mostly due to uric acid accumulation, due to underexpression of uric acid level. But unless I check, but let me see whether there is a correlation between gouty arthritis and colorectal cancer. Yes, this one I have to check. I'm not very sure about this component. And
Okay,
colorectal cancer. Then Venetia, you raise your hand or you just lower? Yes.
No, it's from before.
Okay. So it is by error, yes?
Yeah.
Okay, good. So by the way, if you are really interested in cancer, there is a lot of studies. So you can actually go through it when you get time. If your plan is actually to work more in the oncology area in the future. Then, according to epidemiological studies, it is very common, by the way, in developed countries. So that means it will tell you there is like a correlation between environmental factor or dietary factor in the development of colorectal cancer. So the rate is comparatively lower in developing countries, but still nowadays it is actually emerging. Then the incidence is greatest among men. I don't know why. 1.5 times greater as compared to women. And the median age of diagnosis is usually 68 years. So by the way, it is very unlikely to make a diagnosis below the age of 40. So it is most of our patients are older when they come to colorectal cancer. And greater than 90% of the colorectal cancers are adenocarcinoma. Yes, so that means it originated from the glandular cell. Then 2/3 of this cancer will arise from the colon, and the remainder will be from the rectum. So you can actually even imagine, based on the epidemiology, the cancer is very common in the colon as compared to the rectum. So is also one of the epidemiological studies you are going to note. Then, what are the possible risk factors in colorectal cancer? The biggest risk factor is age. As we age, normally the risk is very high. So that is why in more than 70% of the cases are diagnosed in older adults above 65 years of age. Then you can actually even see there is a correlation between high fat and low fiber diets. So that is one dietary factor. There is also a correlation between alcohol and smoking and colorectal cancer. So maybe in the future you have to assess those things. So then obesity or physical inactivity increases like in the risk to fall there. But remember, those are epidemiological studies. Then if a patient is actually having inflammatory or bowel disease, like either ulcerative colitis or Crohn's disease, the risk is usually very higher. So in the future, even when you take history for that kind of patient, you have to find out whether they had any problem in the past, especially with ulcerative colitis and Crohn's disease. Then family history. But the component of genetics is also very high in colorectal cancer. So you have to find out whether the patient was having family history of cancer or not. So what is very important, specifically from the dietary factor, is the hybrid diet is really strongly correlated to colorectal cancer, and it is due to the heterocyclic amine that is generated as a result of the cooking. So you can actually even further investigate what studies has been done on this area. But especially in terms of evidence, please look out the specifically in terms of look at any meta-analysis or systematic review done about the correlation between high meat and colorectal cancer. So what was the prevalence from the pooled effect? Meta-analysis is actually and systematic review, they are the highest level of evidence because they're actually pulling many studies together to come up a conclusion. So that is why you just read further what is really what was the studies from meta-analysis and systematic review in this regard. Yes, so those are the only known risk factor, but the strongest is usually age. So as we age, our risk is very high. Then screening, the recommendation is for average risk. Remember what we said about average risk? No family history of cancer and no any genetic mutation. So that is average risk. For average risk, the guideline recommends like a screening for colorectal cancer is usually recommended at the age of 50 years. So the moment the patient aged 60, 50 years, it is good to undergo examination. Then annual fecal occult blood examination can be done. Also, I think what is very common is normally the digital rectal examination. Remember, the fecal occult blood can be even, but anyways, if the cancer is normally, if the bleeding is actually around the anal area, usually the blood is actually fresh. But anyway, this fecal occult blood testing is not really a confirmative screening because like peptic ulcer disease or any bleeding across the GID can also increase fecal occult blood. Yeah, I think mostly they use digital rectal examination for screening. So this one is actually the most common screening. Digital rectal examination is the most common screening for colorectal cancer. So this is the American Society of Cancer screening recommendation for colorectal cancer. So if their average age, average risk began at the age of 50 years. If the patient is actually having family history of cancer, began screening at the age of 40 years. Yeah, that is the recommendation. So for breast cancer, if you remember, like for average risk, the recommendation is usually if they are willing, let them start from the age of 40 years. But for high risk individuals, usually at the age of 30 years, screening is usually very, very important. Okay, so those are the recommendation and ways, the general recommendation from the American Cancer Society. But if you want the details, you can actually read. But those are the most important things that I mentioned for high risk. Start at the age of 10 years. That is the recommendation. Now, is it possible to prevent colorectal cancer? Okay, currently there is no pharmacological agent that is approved for prevention, but there is actually a lot of studies which is reporting about the role of COX inhibitor that can actually reduces risk of colorectal cancer. So the aspirin, NSAIDs, and selective COX inhibitors, they do have actually some risk of reduction of colorectal cancer. Aspirin. But what is very well studied is about aspirin. So maybe if you are interested, read further. There, aspirin is really having a protective in cancer and in the prevention of colorectal cancer. So the latest information I read about aspirin, the correlation between the use of aspirin with colorectal cancer is actually aspirin is protective. But how normally they assess, aspirin is one of the most common medication that is commonly used in cardiovascular patients because of antiplatelet activity. So because of that, those patients who are taking aspirin low dose, 75 or 81 milligram, they do have low risk of having colorectal cancer as compared to the other counterpart. That is why they finally concluded aspirin has some role in the prevention of colorectal cancer. So how? I will come later in the pathophysiology, because the pathophysiology of colorectal cancer, overexpression of prostaglandins are really the major causes in the proliferation of the colorectal cancer. Because of that, anything that antagonizes the prostaglandin overexpression can actually reduce risk of colorectal cancer. Why they did a lot of study, you remember the other NSAIDs, we don't use them for long period of time. Yes, because aspirin is the one which is actually antibiotic that can be used for long period of time. Then apart from that, someone is actually taking a lot of calcium containing diet, reduces mucosal cell proliferation, so it is binding to bile salt in the intestine. So in ways, calcium containing diet are protective from colorectal cancer. So there is also a study about this. Okay, then now let me take you about the pathophysiology of colorectal cancer. So it is a multi-step process that involves different alteration in the normal bone epithelium. There is a possibility of genetic change and also expression of COX-2 or expression. So that is why, like those drugs which is inhibiting non-selectively COX-2, they're highly protective. So in the genetic alteration, when there is activation of the mutation of oncogenes, activating a mutation of the tumor suppressor gene, and DNA mismatch repair, those are some of the possible pathophysiologic activities that can be conducted in the colon and rectal region. Then if there is any of those genetic changes, there is high probability the patient will have colorectal cancer. And apart from that, a COX-2 overexpression can induce colorectal cancer cells. So how? It influences apoptosis, programmed cell death, and other cellular function in the colon cells and overexpression of the epidermal growth factor receptor. In such a way, COX-2 overexpression is also involved in the pathogenesis of what? Colorectal cancer. So that is why NSAIDs has some role in this occasion. Then the other thing to note is what are the clinical presentations of colorectal cancer. So most of the patients are asymptomatic in the early stage of the disease. That is why most of the time, or most of the doctor, they normally complain just, it could be an indigestion, it could be peptic ulcer disease. They check a stool examination for a parasite, no observable parasite is seen. Then they say that I just know some indigestion, maybe you is not a problem. Then keep on, this kind of thing is just keep on repeating itself without resolution. So if someone is having that kind of issues and older, it is good to undergo screening for colorectal cancer. Then mostly changes in the bowel habit, abdominal pain, anorexia, nausea, and vomiting, and weakness if anemia is severe. Remember, as a result of the tumor, there is a possibility of bleeding. Because of that, most of our patients, they develop anemia. That is why in the future, maybe I will ask the Venetia's group to give us information whether the hematological profile for that patient is really normal. But I don't think so, because she's also taking Folfox regimen that can cause bone marrow suppression, and she's actually might have bleeding. Then there is a possibility of anemia. Then the patient can be very weak. Then blood in the stool and weight loss is really very, very common. Specifically, blood in the stool is very common. Okay. Then how do we make up with diagnosis? So like other type of solid malignancy, biopsy is the gold standard, but there are also other tests we can consider. Maybe look at the hemoglobin level because of blood loss, because some people, they can complain there is like blood in the stool. Then positive fecal occult blood test is also very, very important. Yes. Then other thing you are going to note is assess the liver function test. Remember, why we are assessing the liver function test is because of metastasis to the liver is very, very high. Yes. So look at the liver function test. Then apart from that, the most common marker that is usually done in colorectal cancer is carcinogenic antigen. Is usually very high in most of the cases. But the normal values is less than 2.5 for non-smoker and less than 5 nanogram for a smoker. So if the value is actually very high, there is a possibility. Maybe can someone normally remind us what was the CAA values for that patient you mentioned, Venetia, or Annette, or any other members of the group? What is the CA, the carcinogenic antigen tumor marker level? Do you recall, or?
The pharmacist just told us that that is the marker they look at.
Okay, but you didn't see the values, huh?
No, we didn't.
Did you manage to go through the medical record of the patient?
No.
We were told that she just came. I think she just came for for treatment here, because there was no, like, this hospital didn't have a lot of history about her, because she just comes for chemo. So that day she was being discharged after coming on Tuesday.
Okay, but how is the oncology department of Kenyatta or University Hospital? Was it really like very comprehensive in terms of like facilities and even the patient population?
Yes.
Okay, fine. So it can be one potential study site in the future, yes?
It is a very potential study site.
But how is the politics there? You know, especially with like those bigger facilities, there is a lot of like politics. So this really like manageable, like the staffs are supportive. So those kind of things, how is it?
Yeah, so they're very good. They took their time to like come and teach us and help us go through the whole logbook.
Okay, good. That is good. So by the make sure as much as you can by there, the theory part you really had done significantly. So unfortunately, just because of COVID, there was actually a lot of disruption. So you are not able to do the practical component. So as long as you are there, make sure you maximize learning. Yeah. So you lead, as I said, you normally lead even the person who is actually accompanied, but give more emphasis with those people who are already there. So then you bombard a lot of questions, ask them, show your interest. Then in such a way you can actually maximize your learning. So I think that is my home take message for all of you, so that you will not be actually like feel strange when you are actually going for attachment next, or I don't know, next semester or another semester, but very soon anyway. So take initiatives, read more, because at least you have seen the cases, then read more. Then when you come to Matari, you read psychiatric cases before you come, then we shall have more interaction and maximize learning. Okay, good. So there is a possibility, but in the future, by the way, you have to go through all those things. Then imaging test, chest X-ray, CT scan. This one is just to assess whether there is a spread of cancer to other site. So that is where we are going to look at it. Then, of course, biopsy is the gold standard in the diagnosis of carcinoembryonic, in the colorectal cancer. Then, by the most common markers are the two of them in colorectal cancer, but this one is most commonly used. CAA is the most commonly used, but CA 19 to 9 can also be used. You can actually, even the positive rate is very high. I think that is why it's commonly used in colorectal cancer. Comparatively, the positivity rate is very higher for CA as compared to CA 99. Yeah, but both of them are the most commonly used tumor marker in colorectal cancer. Now we're heading to the staging. Yes. So what is the time now? Or I check from my end. I don't have my phone. Oh, okay. So the staging of colorectal cancer. So it is usually staged based on a TNM classification system. So stage 1, stage 2, stage 3, stage 4. Then stage 1 is confined to the colon. Stage 2 is it can actually penetrate the wall of the colon into the abdominal cavity, but it does not invade any local lymph nodes. So lymph node involvement starts from stage 3. So if there is one or more lymph node involvement, but not spread to the distant organ, that is when we are going to say the patient is having stage 3 cancer. Stage 4 is when there is metastasis, distant metastasis. This is normally as we have discussed in the previous session. So this is how it look like depending on the staging. You can actually even see how the tumor size look like when they're stage 1, stage 2, then stage 3, then stage 4. Yeah, that is metastasis to different. Now, the next aspect we are going to discuss is about how do we manage colorectal cancer. What is the goal of therapy? Yes, the primary goal of therapy for localized disease is usually curative. So, like if a patient is having stage 1 to stage 3 colorectal cancer, the goal of treatment is usually curative. However, if a patient is having stage 4 disease, there is palliative therapy for metastatic type of cancer. Okay, like for advanced stage, that is stage 4, the treatment goal is normally palliative. Then for operable disease, stage 1 to 3, then now this is where we are going to have normally the surgery is really part of the treatment modality. So most of the time, if a patient is having stage 1 to 3 disease, most of the treatment modalities usually come surgery, surgical resection will come first, yeah, with the goal of curative approach. Then most of the time, if a patient is having stage 1 colon or rectal cancer, usually surgical alone can be sufficient, and adjuvant therapy, guideline recommended adjuvant chemotherapy is not indicated because there is no difference in terms of outcome whether you do surgery plus chemotherapy and surgery alone in stage 1 cancer. That is why in stage 1 colorectal cancer, most of the time we don't consider adjuvant chemotherapy. Then about the use of adjuvant chemotherapy in stage 2 disease is usually controversial. So because studies has not been shown to be superior to surgery alone with exception of high-risk patients. So studies normally show there is no difference in terms of outcome between surgery and giving surgery plus adjuvant chemotherapy. So most of the guideline recommends like for stage 2 disease is controversial, but high-risk patients consider adjuvant chemotherapy. So don't forget, surgery is usually given for all, stage 1, 2, 3, but stage 1 surgery alone might be sufficient. Stage 2 controversial, but considered for high-risk patients. But for stage 3 and onwards, that is when you are going to consider adjuvant chemotherapy. So if a patient is having that problem, adjuvant chemotherapy is actually part of the treatment modalities that could be considered. Then, according to our guideline, what are the adjuvant chemotherapies that are most commonly given when a patient is having colorectal cancer? Colorectal cancer. Okay, then 5-fluorouracil-based chemotherapy is usually the standard of care for adjuvant treatment of colorectal cancer, either a single agent, but more commonly in combination treatment. Now, the group that went to Kenyatta University, for sure, they have mentioned about the FOLFOX regimen, and there's also a FOLFIRINOX regimen. I will come, and there is also a FOLFOX 6, which is known as modified FOLFOX regimen. So, the FOLFOX, by the way, the FOL stands for folinic acid. Then F stands for fluorouracil. Then OX stands for oxaliplatin. Yes, like FOL is folinic acid, F5FU, OX is oxaliplatin. But so far, by the way, I did a search for quite a longer time to get what the word for, like this number 4 stands for. But let's say consider it just naming, yeah? Because from my research, I've never seen any definition about what does the word stands for in the FOLFOX 4, even in FOLFOX 6 regimen. Anyways, maybe you can search and find out. Then the FOLFOX regimen is usually given for 6 months for adjuvant treatment for colon cancer. So remember, folinic acid is also known as leucovorin, 5-FU oxaliplatin, that can be given in combination with IV bolus and continuous infusion. So this is the most common treatment regimen. Sometimes even capecitabine oral treatment can be given like day 1 to day 14, then you repeat every 21 days, or its cycle can be the other alternative regimen in case if the patient cannot tolerate combined chemotherapy. Then what I'm going to discuss more is about the most common protocol for colorectal cancer is the FOLFOX 4. So what is the dose of oxaliplatin? By the way, most of the time we give day 1 and day 2. So that means the patient is supposed to be admitted in the ward for 2 days before they released for chemo. During chemo day, they just admit for 2 days. Then, like we're going to give day 1 and day 2, then we repeat every 12 cycle, every 2 weeks, then we're going to give for 12 courses or 12 cycles. 12 cycles. Okay, so day 1, normally we give 85 milligram oxaliplatin along with leucovorin, then intravenously for just 2 hours. Then followed by, what is the next infusion is normally you give 5-FU 400 milligram IV bolus, then in the form of infusion for the remaining 22 hours. That means you calculate the loading dose for 400 milligram per meter square for 2 hours, sorry, a bolus dose, then for 24 hours, this is normally the dose you are going to give. Calculate 600 milligram per meter square, then you give a slow infusion. That is what we give in day 1. Day 2, we normally give only leucovorin and leucovorin and 5-fluorouracil, the same dose, the same duration. Leucovorin is usually given prior to 5-FU, and I will mention why folinic acid is administered in the FOLFOX regimen. Now you repeat every 2 weeks, then you are going to give the patient for 12 courses. That is 12 cycles. So by the way, this 12 cycle is equivalent to 6 months. So that means to complete the adjuvant chemotherapy, the patient has to be in the hospital. They are supposed to come frequently for the duration of 6 months. The neuropathy and neutropenia is actually very common. So neuropathy is mainly due to oxaliplatin, but the neutropenia is mainly due to maybe it could be 5-AU, even oxaliplatin. Oxaliplatin can also cause even neutropenia, but it is not very severe. So the neutropenia is mainly due to the 5-fluorouracil. So that means, according to various studies, like this regimen is actually the most the most effective. That is why they are called, they have been used for quite some time. But we do have other regimen, flux regimen. That means leucovorin. Flux regimen contains leucovorin plus 5-FeU and even oxaliplatin. Okay, I don't really see the difference, but only the difference is the duration of administration is actually different. Otherwise, it is the same drug. There is leucovorin, there is 5-FeU, and there is oxaliplatin. Okay, anyways, but what is very common is this one. But some doctors normally even they use modified FOLFOX6 regimen. By the way, according to various clinical trials, whether the patient is taking FOLFOX4 or FOLFOX6, the treatment outcome is normally still the same. And the only difference is the dose of oxaliplatin. The dose of oxaliplatin is the same, 85, and the only difference is actually the dose of leucovorin and 5-FeU will be different. That is the only difference, by the way, because leucovorin normally we give 400 milligram in this case, but the other time we normally give 200 milligram, but the bolus dose of 5-FeU is the same, 400 milligram, and the other dose is normally 1200 milligram for 2 days is usually considered. So one thing to note, the difference between FOLFOX4 and FOLFOX6, in terms of outcome, they are the same. The only difference is the dosing of leucovorin and 5-FeU is different. Otherwise, there is no difference in terms of outcome. Then there is also another regimen, Delox, capecitabine plus oxaliplatin can also be considered, but those two are the most common in our setting. So now the question is, why folinic acid is given with 5-fluorouracil? So remember, even oxaliplatin should be given with oxaliplatin. Oxaliplatin is usually given with leucovorin first before we give a bolus administration of 5-FeU. So the role of leucovorin is not to rescue from anemia. The role is when you add leucovorin in the FOLFOX regimen, it increases the affinity of 5-FeU for the enzyme, which is known as thymidine synthase enzyme. Remember, 5-FeU, the principal mode of action is by inhibiting thymidine synthase enzyme, it can actually reduce DNA and RNA synthesis in the cancer cells. So when you combine leucovorin with 5-FeU, now the affinity of 5-FeU will be enhanced, then it increases the pharmacological activity. So according to different guidelines, it is usually more effective when you give them before 5-FeU. So that is why if you see the FOLFOX regimen, oxaliplatin is usually along with leucovorin usually 2 hours before infusion of what? 5-FeU. That is why it is usually given prior, because it is more effective when you give them before. And mostly we give them intravenous bolus or continuous infusion. Yes, sir. But the major issue is the moment you combine with leucovorin, you are increasing toxicity of 5-FeU because the pharmacological activity will be enhanced. So specifically leukopenia, mucositis, and diarrhea can be enhanced, but it is very, very effective in terms of tumor control. Okay, so this is the adjuvant medication we are using in FOLFOX in majority of colorectal cancer. So you do surgery first, then stage 3, you normally consider adjuvant chemotherapy is FOLFOX4 or FOLFOX6. Then how do we treat colorectal cancer patients in metastatic setting? So the goal here is just palliation, because there is no way we are going to cure. Then the surgical resection can also be beneficial. But yes, please.
Our patient was using FOLFIRI regimen, not the FOLFOX. What's the difference? Like, is FOLFIRI more efficient than the FOLFOX?
No, FOLFOX is more efficient, but in case if some patient is actually some problem or not effective, FOLFIRIN is irinotecan. Was it included here? I think I must be included somewhere. Yeah, I will see in the, this is FOLFIRI, irinotecan. So irinotecan is replaced by oxaliplatin. So all the regimens are approved, but The FOLFOX one is the most effective, but in case the patient is not responding, maybe we can consider FOLFIRINI. Yes. Venetia?
So, and they were also using Vivacizumab.
Yes.
But we didn't know why they were using that.
Bevacizumab is also part of the treatment regimen for colorectal cancer, so it can be considered. Yes, it is one of the monoclonal antibody. I don't know whether I mentioned here. You know, I normally pick like what is the most treatment regimen in our setting, but it can be considered as the combination therapy in the colorectal cancer patients. It is very effective type of monoclonal antibodies. Not only even in cervical cancer, it can be considered. And cervical cancer, even the guideline says if you combine cisplatin, carboplatin plus paclitaxel along with bevacizumab, you are going to get more outcome. But because of availability issues, is really a challenge. Yes. Have you seen even this one? Bevacizumab plus 5-FU can be considered. Yeah, even in the metastatic setting. Yeah? Yes. So, you know, especially in selecting regimen, there is a lot of variation. Like from my experience, I had it before. Some prefer FOLFOX because they know very well about ADR and etc. Some prefer, oh, I don't really want to get oxaliplatin because of peripheral neuropathy it is causing, and even other side effects. So I prefer FOLFIRINI and etc. But the guideline says like FOLFOX is like the most commonly used regimen. Yeah, in terms of outcome, it might not be as different with other regimen, but you start with FOLFOX. If no response, that is when you are going to consider other protocol. Yes, and also availability is also another issue. You know, sometimes if oxaliplatin is stock out and if you do have irinotecan, yeah, you replace it with irinotecan because irinotecan, this FOLFIRINI regimen is also approved in even in adjuvant setting, not only even in metastatic setting. Yeah, remember what we are using in adjuvant setting, they are actually effective in managing like symptomatic control in advanced stage of the disease. So we can use, so we are still using the same FOLFOX in metastatic setting and the same FOLFOX in adjuvant setting. Okay, any other question? So the patient is on FOLFOX, huh? Is it FOLFOX 4 or FOLFOX 6, the modified one? Or you don't remember?
It was FOLFIRI.
Yeah, this one, huh? Because like, yeah, remember the first line regimen in advanced stages are either FOLFOX or FOLFIRINI or bevacizumab plus 5-FU in case if the patient cannot tolerate like many chemotherapeutic agents together. Yeah, it could be the scenario why, but it's just the oncologist normally will decide which one regimen to pick, depending on availability issues. Okay, good. Now, can you see like all those regimens are possible? But then what is the dose limiting toxicity of adenotican? Dose limiting toxicity of adenotican?
Severe diarrhea.
Sorry? I didn't hear what you said. What is the dose limiting toxicity of adenotican?
Diarrhea.
Diarrhea, yes. Remember, in acute stage, there is actually cholinergic overactivity, and diarrhea is the most dose and rate limiting side effects of adenotican. And we have to manage very well, otherwise the patient will end up having dehydration and leads to hypovolemic shock. Okay, good. Now, this is the regimen in metastatic setting. So capecitabine can be used as a monotherapy. Yeah, specifically when the patient, you know, the goal here is just palliative. So, and even 5-FU with leucovorin can be used as a first-line agent, like if the patient cannot tolerate a 3-drug combination FOLFOX. Maybe that is why they normally give even yes. Then the modified FOLFOX can also be considered. I mentioned about the modification is not the part of oxaliplatin. The modification is normally you give leucovorin even day 1 followed by 5-FU 400 milligram IV bolus, then 1200 milligram per meter square per day for 2 days. Yeah, usually over 46 hours over 46 hours. That is almost 24 plus 24, yeah, 23. Remember, the 2 hours is normally for the oxaliplatin infusion with leucovorin. So that is why usually the infusion will last for 46 to 48 hours, the remaining hours. Then we repeat every 22 weeks, still 12 courses. So the modification is just, I think why it is called modified is just because of the dosing of administration and the dose of leucovorin and 5-FU is different, but oxaliplatin is still the same. Then, as you said, folfirine can be used. Fol stands for folfirine. Fol stands for folinic acid. F stands for 5-FU. IRI stands for adenotican. So you can actually even say this is the duration. So adenotican, this dose plus leucovorin, you give them in the then plus bolus of 5-FU, then followed by 5-FU infusion for 46 hours. Yeah, then you repeat every 2 weeks. Okay, so this is how a folfirinics regimen look like. So what is the dose limiting toxicities? Nausea, diarrhea, mucositis. Especially mucositis is actually due to what? 5-FU. Diarrhea is mostly due to adenotican. Neutropenia can also be due to 5-FU. Okay, so those are the toxicities. So remember, when you are managing a cancer patient, you have to manage the side effect and you have to identify what is the most likely offending agent that causes toxicity in those patients. Okay, now another thing to note is there is a slight difference in management of colorectal cancer when there is a component of rectal. So more often, the treatment is actually similar. But there is a slight difference in the treatment of rectal cancer, especially in adjuvant setting. So remember, in adjuvant setting, like rectal cancer, there is high incidence of local failure, and there is poor overall performance, poor overall prognosis associated with rectal cancer, which could be due to some issues with the surgical technique. Yeah, so in general, the local recurrence and the prognosis is comparatively poor with rectal cancer. And if you see the epidemiology, 2/3 of the cases are usually colon cancer, but 1/3 is normally rectal, but the other is usually both colon and rectum. Sometimes even the anus can be involved. So what is the recommendation if a patient is having rectal cancer only? So if there is rectal cancer only, what you are going to do is you give them 5-FU build chemotherapy in combination with radiotherapy should be offered for stage 2 or stage 3 cancer. For stage 1, you normally do resection only, but here, if there is a rectal cancer only, there is a component of FOLFOX and radiotherapy. So why radiation therapy decreases local recurrence, but 5-FU decreases risk of distant metastasis of the tumor recurrence as well as because it is acts as radio sensitizer. So in short, when there is rectal cancer, when there is in adjuvant setting, consider what? Radiation therapy as well, because radiation therapy will reduces local recurrence, then 5-FU reduces what? Distance, as well as the chemotherapy can be served as a radiosensitizer. So that is why usually radiation therapy can be considered in the rectal cancer only. Otherwise, in metastatic setting, the treatment regimen is actually the same, what has been outlined in the colon cancer. So you have to know those information. Otherwise, there is no a lot of details in the management. Like if you go through in most of the setting, FOLFOX is usually the most common in colorectal cancer. So that is what you are supposed to know. But also don't forget about folfirine because it can be used. Yeah, so in the future, you can actually read furthermore, when do we consider FOLFOX? What is the difference between the two in terms of ADR and tolerability and etc. Okay, so any questions so far, maybe? Any question?
Sir?
Yes, please.
What did we say Bevacizumab does for colorectal cancer?
It is actually like this one is bevacizumab is one of the monoclonal antibodies that is actually prevents like angiogenesis in colorectal cancer patients. So by preventing new blood vessel formation, it actually prevents from colorectal cancer progression. Yes. So the mechanism of action is what we have seen at the beginning when we were discussing about the principle of cancer chemotherapy. It is one of the monoclonal antibodies that can be considered in the treatment.
Okay, sir, thank you.
Okay, any other question? Okay, now maybe just a brief overview to give you some idea. Of course, we have seen the drugs. Maybe even you might actually even started discussing in the pharmacology class. So 5-FU, capecitabine, irinotecan, oxaliplatin, bevacizumab. Those are the most effective regimen that can be used in colorectal cancer management. So it's just like 5-FU inhibits this enzyme, which is the rate limiting step in thymidine formation. As a result, DNA and RNA synthesis will be reduced. So it can be given as IV bolus or IV infusion, as you have seen. Remember, the 200 milligram is the 200 is usually given in the form of IV infusion, and the 400 usually 200 bolus and 400 infusion. Okay, then what is the dose-limiting toxicities of when you give them in the form of bolus? When you give them in the form of bolus, the patient can develop leukopenia and mucositis. So because of that, because of the mucositis, it is advisable to consider oral cryotherapy or ice chips 50 minutes prior, during, up to 1 hour. Why? Those called ice, it causes vasoconstriction so that it reduces the delivery of the chemotherapy to the mucosal areas. So those are one of the prevention strategies. But this is when we are going to give ibu bolus. But when we give in the form of infusion, hand-foot syndrome and diarrhea is the most common dose-limiting toxicity of 5-FU. So the moment you give for that 23 hours or 46 hours in the modified Colfox regimen, that is when you are going to expect hand-foot syndrome and diarrhea can be happened. So please note the difference between the dose-limiting toxicity of 5-FU, bolus administration and infusion. The bolus myelosuppression, mucositis, but the infusion causes hand-foot syndrome and diarrhea. I think that's the reason why I want to talk about. Then capecitabine is the oral prodrug of 5-FU, and it is supposed to undergo like 3 steps in metabolic conversion to 5-FU. Yes, otherwise the mechanism of action is actually the same. Yes, however, the toxicities and pharmacological activities appear to mimic those of continuous infusion of 5-FU. By the way, if you see capecitabine is actually more tolerable than the active drug 5-FU. That is why Zeloda, with the brand name Zeloda, is the most common brand name for capecitabine. Is nowadays is actually commonly used depending on the preference of the medical oncologist. So when you give capecitabine, toxicity, pharmacological activity, it is similar to giving continuous infusion of 5-FU. So because of that, what kind of toxicities do you expect when you give capecitabine? And syndrome and diarrhea is very, very common. Then irinotecan, we have already said about irinotecan. Irinotecan is a topoisomerase enzyme 1 inhibitor that interferes with DNA breakage resealing process. So this one we have already said, it is a prodrug, by the way, that can be converted to active form. Yes, to inhibit topoisomerase enzyme 1 inhibitor. So it causes single-strand DNA break. Then what is the major toxicities? Diarrhea is actually the most common either in the early, late in therapy. But usually in the first 24 hours, it is related to cholinergic overactivity and usually responds to atropine, 0.25 to 1 milligram IV. But the late diarrhea usually happen after 7 to 40 days of treatment of adenotican infusion, and mostly because there is no infection cause of diarrhea, anti-motility agents such as loperamide can be used for milligram initially, followed by 2 milligram every 2 hours until diarrhea free for 12 hours. Okay, if diarrhea does not stop or worsen, it may require even hospitalization as well as even discontinuation of therapies. Yes, but most of the time you start with loperamide. If no response, you hold the treatment. So those are the toxicities of adenotic cancer. Don't forget, please. In acute phase, we give atropine, but in late phase, we usually give anti-motility agents can be considered. Now, the other thing we are going to discuss in detail is about the oxaliplatin. Remember, oxaliplatin, we have discussed, it's just like refreshing your memories. And of course, we have not mentioned in detail about how we are managing the acute neuropathy and chronic neuropathy as a result of oxaliplatin. So oxaliplatin has minimal renal and myelosuppressive effect, and even nausea and vomiting as compared to other platinum analogs, but it has dose-limiting toxicity of causing neuropathy, either acute or chronic. Acute usually occur within 1 to 2 days of dosing or resolves within 2 weeks of treatment. Usually occur in the peripheral areas in the lower extremities. Then exposure to cold temperature or cold objects are usually exacerbate the neuropathy due to oxaliplatin. So what do? We have to give our patients proper instruction to avoid cold exposure, or maybe proper wearing, proper wearing, proper dressing, and even avoid cold drinks are usually very important. Then in the chronic management, usually occur after 8 cycles of oxaliplatin. So chronic neuropathy occur usually after 8 cycles of oxaliplatin. So it is usually characterized by the defect that can interfere with daily activities. So remember, in this condition, like dose reduction or discontinuation of the medication can resolve the chronic neuropathy. And most of the time, it usually happens after 8 cycles of oxaliplatin administration. Yes, so almost more than 50% of the patient will develop chronic neuropathy, and the best strategy is dose reduction, or when the moment the completion of the treatment, the problem will disappear. Yes, then bevacizumab, we have mentioned earlier when we are discussing, is a recombinant monoclonal antibodies that usually inhibits the vascular endothelial growth factor, and it is normally a remember this growth factor is a pro-angiogenic growth factor that is found in many cancer cells, including even in cancer cells. So that is why this one is normally a pro-angiogenesis growth factor, which is found in cancer cells, including colon cancer. So if you inhibit this one, you inhibit blood cell formation and metastasis of the cancer. So in such a way, it can be used in the management of colorectal cancer. Mostly is usually given in advanced stage of colorectal cancer. Okay, so what is the dose limiting toxicities? Do you remember, by the way, we have mentioned about hypertension, we have mentioned about thromboembolism as a result of bevacizumab, and we have said also the interference with the normal wound healing is also very common, and even some kind of renal injury can also be happened. So if there is hypertension, we normally give oral antihypertensive agents to limit the hypertension as a result of bevacizumab. So as we have mentioned, even how bevacizumab, how does bevacizumab cause hypertension? Any feedback? How does bevacizumab causes hypertension? I mentioned by the way when I was discussing the first part. Any other? Any trail?
Because of vasoconstriction.
Yes, it is actually because of the vasoconstriction. These the vascular endothelium growth factors are normally vasodilators. The moment you inhibit, it causes vasoconstriction. Yes. Any other? How does it cause thromboembolism? Thromboembolism? Any trail? Oh, you have forgotten, huh?
Can we say because when it interferes with wound healing, then it increases platelet aggregation on the site of injury, resulting in such events?
Okay. Yeah, but the interference with the wound healing is actually, it has some activity, and even vasoconstriction, the level of inflammatory markers can be reduced, so it can delay. But the thromboembolic event is mainly, do you know about this vascular endothelium growth factors? They're actually important for repairing of damaged endothelium. So the moment you inhibit the vascular endothelium growth factors, what will happen? If there is a damage, now it can actually increase risk of what? A platelet aggregation and fatty deposition can happen, and that can ultimately cause even a clot and even a blockage. So that is the principal mechanism. But then, if you are interested more, you can read further. Even like I shared, even some of the information in the introductory session. Okay, so those are the dose-limiting toxicities if we give bevacizumab. Then, how do we assess the outcomes of evaluation? So, if the patient is treated definitively with localized disease, it has to be monitored regularly, specifically for a minimum of 5 years. Remember, majority of the recurrence usually happen in the first 5 years of definitive treatment, but mostly in the first 2 to 3 years, recurrence is usually very high. The recurrence rate is usually very high in the first 2 to 3 months after completion of adjuvant therapy. Then other thing you are going to note is history and physical examination and carcinogenic antigen should be performed every 3 to 6 months for the first 2 years, then semi-annually thereafter. So this one is just for monitoring. Yes, you do the first 3 to 6 months for the first 2 years, yeah, because it's very important, because the recurrence rate is very high. Then after that, you can actually even monitor every 6 months. Okay, for 5 years is usually very key aspect. So this is all what I have this is all what I have for colorectal cancer. Now it is time for question and answer. So did you learn something about colorectal cancer? So any question? Let me hear any question first. Any question? Possibly.
Yes.
Maybe can you outline some of the risk factors of colorectal cancer?
The main.
So it is good to know also about the anatomy of the prostate. By the way, if you know about the anatomy of the prostate, you can actually even say something about, like if there is enlargement of the prostate gland, what will happen about the urine outflow? There is a possibility of blockage, and most of them, they are complaining about pain during urination, dribbling, and actually is really very common. And finally, how do we manage treatment? How do we manage prostate cancer patients? Okay, now prostate cancer is actually, or a prostate gland is, or cancer is actually began when the cell in the prostate gland starts to grow uncontrollably. Then it is actually found only in male, and it's actually involved in the production of some of the seminal fluids that has some role in protection of the sperm. Then, if you see the anatomy, the prostate gland is actually below the bladder and in front of the rectum. That is why they are using digital rectal examination, even for prostate to see whether it is enlarged or not. Below the bladder, in front of the rectum. So because of anatomical location, below the bladder, when the tumor grows, it can compress the urine outflow. Then remember, the size of the gland changes as we age. Yes. So this is how the cancers, or this is just the anatomical and the anatomy of the prostate gland. Here is the bladder. You can actually even see the urethra and the tumor, or this is the prostate gland, and you can see there is a tumor somewhere here. Yes, sir. So you can actually even imagine how, like, this is normally the cross-section of the prostate, so it can be enlarged. So if there is a growth, and what will happen, it can actually even compress and normally causes destruction in the urine outflow. So obstruction of urine outflow can be happened in case of BPH or in case of even prostate cancer. But the BPH is like benign prostate hyperplasia, it's just a benign tumor. But if a patient is having BPH, there is high risk of developing what? There is high risk of developing what? Prostate cancer. So that is why for BPH, even considering surgery is also very important. Usually prostatectomy, removing the tumor site, is also involved. Then what is the epidemiology of prostate cancer? But it is very common in the US, and leading cause of cancer is among all women. I don't know. I think the current report might be even the first. So I think this epidemiology is from the US. So we don't really have many studies in our setting. Yeah? It is very common above the age of 40 years. That is why if a man is above 40 years, it is advisable to undergo screening for prostate cancer, because it is below 40, very minimal, very minimal. So that is why every man is at risk. So if someone is above 40, screening is usually recommended to capture early. Yeah. Yes, please.
Is there a particular reason why it is more prevalent above 40 than below 40?
There is no reason, but the main reason is actually probably, those cancer, like after they undergo mutation, like the whole process of carcinogenesis will take longer time, and they do have prolonged exposure. Like the more the prolonged exposure, the higher the risk of developing malignant transformation. You can actually even imagine, like when they start producing the androgen, like what is the exposure level below 40 is minimal. But if they are actually above 40, means you can expect the duration of exposure for androgen, which is the main growing signal, will be longer. That is why it is very common in above 40 years of age. Yes, that is the main reason, by the way. Yeah, it is even like breast cancer. Like the longer the exposure of the hormone, the higher the risk, or the higher the prevalence. So the higher the risk, the higher the prevalence. So the prevalence of breast cancer is very high in postmenopausal women as compared to premenopausal women, because that process is usually taking longer time. So you can actually even look at it, the Global Cancer Report of 2018. So prostate cancer is actually, in terms of leading incidence, is fourth. In terms of mortality, is actually where lung, colorectal cancer, stomach, liver, breast cancer. It was not even here. In fact, this was not really the right. This one is not supposed to be here anyways. This one is not supposed to be here. I thought there was a component of prostate. Yes, from here, but there is no. Okay, anyways, you can actually even see in terms of incidence, it is actually very high in the force globally, according to the Global Cancer Report of 2018. Then, in terms of risk factors, age is the greatest predictor. So by the way, like when you say predictor, correlation, there are different terms. I don't know whether you have gone through when you are discussing about in the research method class. When you say there is a correlation, means like this is just a link. when you say association, like there is actually there is an association between one, but when you say predictor, like it is more related to causality. Causality. It is more related to cause. Yes, correlation, association might not tell you one factor is actually a cause for the other, but when you say predictor in terms of research, that means the possibility of causality between the factor and the outcome is actually very high. So that is why when you say age is a predictor risk of this means like there is actually a strong causal association between age and prostate cancer. So you have to know by the way. So if you see a study predictors of prostate cancer treatment outcome, that means like that predictors are having a stronger association that actually explain the causality between that factor and the outcome. So according to this, age is a greater predictor. So it is very rare under the age of 40s, the reason I mentioned before, and it is very common in older population. Like 70% of the cases are usually diagnosed in older population above 65 years. Okay, then, so why it is very common in older population is the older age have a greater lifetime exposure to the hormone testosterone, a non-growth signal for the prostate. That is why as we age, even the size of the gland will actually enlarge because of the growth, like the lifetime exposure for the androgen is actually very, very longer. So it is very high in older population. Then family history is very important. So if they do have first degree relative, the risk is actually even higher. Then I don't know about there are some reports about cadmium exposure and decreased risk of colorectal cancer, but sorry, prostate cancer, but I don't really know. Then there is also an association between high fatty meat and high meat and high fat. They increases risk of prostate cancer. Then there's also about some correlation between decreased intake of vitamin D containing food and beta carotene increases risk of colorectal cancer. So that it is advisable to increase those vitamin D containing food items are usually protective from prostate cancer. Then the other thing you are supposed to know is up to 80% of the case of prostate cancers are usually hormone dependent. That means it is related to the production of androgen. That is why men are the only population that is affected by prostate cancer. Then it does not occur in castrated individuals. When you say castration, that means they have already removed the testis. Testis is already removed. So if testis is actually removed, which is the main source of androgen, like more than 85 or more than 90% of androgen is produced by testis. So it cannot happen. Even some guidelines recommend is if the person is high risk, it is good to undergo castration before they develop prostate cancer. But if they undergo castrated means their reproductive fertility is not possible after castration. Then do you know it is low incidence in cirrhotic patients? Do you know by the in cirrhosis normally suppresses the hypothalamus pituitary gonadal axis, hypothalamus pituitary and gonadal axis. So by doing so, it reduces the level of androgen or testosterone mainly. So in such a way, the incidence of what you call prostate cancer is usually very low if someone is having liver cirrhosis. Do you know by as a result of reduced the production of androgen, cirrhotic patients they usually develop gynecomastia. I don't know whether you encounter, maybe by I'm advising you also apart from seeing cancer patients, find out even and go when you go to that place, look at and find out whether there is any liver patients or any alcoholic liver disease and find out and go through at least a teaching case when you go to that setting as well. So gynecomastia is very common in cirrhotic patient because of reduction in the testosterone level. Okay, do you know African American have a 50% increased testosterone level, so they're high risk. And according to even some racial studies, like racial difference, Japanese normally they do have reduced level of 5-alpha reductase enzyme. Do you know about the role of 5-alpha reductase enzyme? It is actually involved in the conversion of testosterone to dihydrotestosterone. By the way, this one is usually done by 5-alpha reductase enzyme. So this one is the most active form of testosterone that can promote the growth of prostate gland. So because Japanese have reduced level of this enzyme, then the risk of prostate cancer is comparatively lower as compared to the other population. So do you remember, I don't know whether you have been going through in the pharmacology part, we do have a drug that can inhibit the conversion of testosterone to dihydrotestosterone. We call them 5-alpha reductase enzyme inhibitor in the management of benign prostate hyperplasia. Yes, it can be used, like the finasteride can also be used. Then go and find out about the role of 5-alpha reductase enzyme inhibitor in the management of alopecia. Yes, go and find out. There is a possibility you are going to consider to manage male pattern baldness to give 5-alpha reductase enzyme inhibitor, and then you will tell me later. Then this is all about the risk factor. So from the whole aspects, the most dominant part is actually the hormonal aspect is the most dominant, and it is mainly related to age. Yes, because of lifetime exposure is very longer. Then when you come to the pathophysiology of prostate cancer, adenocarcinoma account is the most common, like 95% of the prostate cancer. Yes, please.
I have a question.
Yes, please.
I read an article that men who have been done a vasectomy are somehow at a risk of getting prostate cancer. Is that true?
According to my research in this regard, they are saying the risk is actually very minimal. It is very minimal. I don't know whether I shared you the contraceptive method, sorry, the hormonal contraceptive from my slide. So you can actually even get from that information, but according to my studies or my research, unless there is any changes recently, the risk is very minimal. So we don't deter a man to undergo vasectomy to prevent, like, to have permanent method of contraceptive. So because the risk is actually very, very minimal. Even hormonal contraceptive with breast cancer is actually very minimal. But with long-term use for many years, there is a possibility of some risk, especially with high-risk individuals. So that is good finding, but you go and counter-check again whether there is like a systematic review or meta-analysis done that shows normally a link between vasectomy and prostate cancer. Yes. Okay, but this one you can get in the Western countries, but I doubt how many people normally do vasectomy in our setting. I doubt. Yeah, most men are very stubborn to undergo this kind of procedure as the method of hormonal contraceptive. But nowadays, even I think there is something which came up with the hormonal method of contraceptive for men. I don't know how far it has gone, but it's coming up in the future. Any other question? Okay. So alert me when the time reaches, because I don't have my phone from my end. I cannot check unless I stop the slide. So it is adenocarcinoma is the most common type, but there are other rare types of histology type of prostate cancer, not very common, neuroendocrine cancer, sarcoma, transitional cell carcinoma. So it is the role of the pathologist is normally giving us, but mostly it is adenocarcinoma. Okay, now when you come to the pathophysiology of this condition, normal growth and differentiation of the prostate depend on the presence of androgen, specifically the dihydrotestosterone. So remember, the dihydrotestosterone is the most active growth signal for the prostate gland. So the testes and the adrenal glands are the major source of circulating androgen. I hope you know there is actually androgen for female from adrenal gland. That is why they are having hairs, especially those. The hair growth is usually mediated by androgen around the axial area, pubic areas. So you can actually even say, despite testis and adrenal gland is involved in androgen production, more than 95% of the androgen is produced by testes, which is also known as testosterone. So the primary source is usually the testes. That is why castration is even part of the treatment modality. We call it even oectomy. But around 3 to 5% can be obtained from adrenal gland. Yes, from adrenal gland production. So remember, in the prostate, the enzyme 5-alpha reductase enzyme converts testosterone to the more active form. Yes. So in majority of the early cases of prostate cancer, the tumor proliferation is usually mediated by androgen. So namely, testosterone is the main one, but it can be testosterone is usually the main growth signal. But so in short, in the early stage of the disease, it is primarily due to what? Androgen. But in advanced disease stages, like in case of like metastatic stages, probably the prostate cancer cell may be able to survive and proliferate without even getting signal normally provided by circulating androgen. When this occurs, the tumor is known as castration resistant, or also known as hormone refractory androgen independent tumor. So by the way, there is a scenario whereby you normally castrate the patient. When you check the testosterone level, it is less than 20 nanogram, yes, per ml. Then you have achieved castrate level that the patient is not really improving clinically. So that is where we call it castration resistant or hormone refractory androgen independent type of tumor. So it is very common in the metastatic setting. So in majority of the early stages, it is normally what? Normally what? It is is a normally hormone dependent, but in the later stage, there is high probability of having androgen independent tumor. So androgen therapies are not really effective in that context when it is androgen independent. So this one is just the hormone regulation of the prostate gland. There's hypothalamus at the top, the Supreme Court, maybe pituitary, the High Court. Then you can actually even see now the gland. The testis will produce what? Testosterone. There is also adrenal gland production that is accounted for a smaller percentage. Yeah? Then androgen will be produced, then it will be converted to hydrotestosterone and ultimately promotes the growth signal from the prostate. So that is how, like, all concerted effects from the adrenal gland as well as from the testis produces the active form. Then it binds with the receptor and promotes growth and proliferation. With long-term exposure, it can be cancerous. Okay, then, what are the possible clinical presentations of prostate cancer? Locally advanced disease, localized disease, mostly they are symptomatic. If it is locally invasive disease, there is a possibility of urethral dysfunction because of the anatomical issues. Frequency, urine frequency, distance, and dribbling can happen. Even sometimes impotence can be happen. But in advanced stage, that is where there is involvement of the bone, there is a back pain, spinal cord compression, edema in the extremities, anemia even. But there is a correlation between androgen and stimulation of RBC production in men. So if someone is having like a problem in that area, there is high probability they're developing anemia in ways. because the normal production is suppressed. So anyways, there is a possibility, but mostly those things are very, very common. Then how do we come up with diagnosis? History and clinical examinations are very important. Digital rectal examination, PSA, prostate-specific antigen, is also part of the examination part, but biopsy will be the confirmatory test. Biopsy will be the confirmatory test. But of course, to assess involvement of other parties, we can do bone scan, CBC, and liver function test can be considered. So this graph is to show you, or this table is just to show you about the staging of prostate cancer. Stage 1 is small and only in the prostate. Stage 2 is larger, can involve in both lobes of the prostate, but it is still confined with the prostate. But this one is stage 3 is whereby locally advanced stage whereby there is involvement of the nearby lymph glands or seminal vesicle. But stage 4 is still, there is a spread to other organs such as the bone. That is when we are going to say metastatic cancer. Then if a prostate cancer spreads or metastasizes to the bony, prostate cancer in the bone, not a bone cancer. This one I already mentioned before. But usually stage 4, it has A and B categories, like cervical cancer, if you remember. If it's stage 4A means the cancer has spread to the regional lymph nodes. That is when we get to stage 4A. But when the cancer spreads distant lymph nodes or other part of the body, that is when we are going to say the patient is having metastatic stage of prostate cancer. Okay, then this one is also another form of staging. Stage 1, there is tumor 1, no lymph node involvement, there is no metastasis, but the Gleason score 1. I will mention later, by the way, what is the correlation between Gleason score and at the stage of the grade of the tumor. But the Gleason score is actually the most common score, or that can be used to characterize the staging of prostate cancer. So that means the higher the Gleason score, like the more aggressive the disease is, and the tumor is actually poorly differentiated. So Gleason scale will show you the similarity between the cancer cells from the normal cell from the biopsy result. So the higher the scale, the higher the score means the more the poorly differentiates the tumor, and the more aggressive and the poorer the prognosis. So this is how the staging can be made. But remember, at stage 2, there is no lymph node involvement. But if the size of the tumor is T1, T1B, T2, it can be stage 2. Stage 3, the greater the tumor is T3, but no lymph node involvement. There is also a lymph node involvement even in stage 3 in ways, any Gleason score. But stage 4 is where there is M1. Yeah, mostly when there is M1 means there is distant metastasis. If no M1, this one could be stage 3, 4A. Any T, N1, M node, or any Gleason score. I've not included this component. I think I have included somewhere about the Gleason score of prostate cancer. So I don't know where it is. Okay. Okay, anyways, if the Gleason score is actually, I will include it. If the Gleason score is actually a bit less than 6, we call it like it is, the disease is moderate. If it is between 7, there is low risk, low risk. If it is between 7 and if it is 7, we call it moderate. If it is 10, sorry, 8 to 10, it is normally high grade type of tumor. Yes. So that is how Gleason score is actually very important, and usually the scale is between 6 to 10. Okay, so anything less than 6 is usually a low risk. So there is a strong similarity between the cancer cells and the cancer cell and the cancer cell and the tumor cell. Yeah, that is a well differentiated type of tumor, but the higher the Gleason score, the poorly differentiated the tumor is. Okay, fine. Okay, I think I really want to show that part. I don't know how I skip. Can you see this one maybe? If I forgot to include, can you see like this one? Yeah, 6 and less may be well differentiated at low grade. If the cancer is actually a score of 7, maybe we call it moderately differentiated or intermediate grade. That means there is moderately differentiated means like there is slight similarity. But when you say a Gleason score of 8 to 9, 8 to 10, this is poorly differentiated or high grade tumor. So like the tumor is actually very high grade, and even the prognosis is actually very poor when a patient is actually having this stage of prostate cancer. So I think with that, maybe let me stop for today's session. Then we'll complete on Wednesday. Yes. So I have given you a brief overview about prostate cancer. Now you go and finally read how we are managing prostate cancer, what treatment modalities are available, and etc. So now, any question?